Kaposi sarcoma. Skin lesions of Kaposi sarcoma are painless, non-pruritic, violet papules or nodules on skin and mucosa. Summary: Kaposi sarcoma is a malignant, multifocal, highly vascularized tumor of the endothelial cells that most commonly affects the skin but may also involve the lymph nodes, mucosa, and viscera. It is commonly associated with HIV and can occur at any CD4 count, typically less than 500 per millimeter cube. Diagnosis is confirmed with biopsy. Treatment depends on whether the disease is localized or disseminated. All patients with HIV should be started on antiretroviral therapy. Etiology: Kaposi sarcoma is caused by human herpes virus A, a large DNA gamma herpes virus. Routes of transmission include saliva, sexual contact, potentially via blood transfusion and IV drug use. Clinical features of Kaposi sarcoma: patients typically present with multiple cutaneous or visceral elevated tumors with rapid growth. Most commonly affects the skin, but may also involve the lymph nodes, mucosa, and viscera. It can occur at any CD4 count, typically less than 500 per millimeter cube. Initial stage: painless, non-pruritic violet papules or nodules on skin and mucosa, especially face or oral cavity and chest. Oral lesions in AIDS-associated Kaposi sarcoma are common. Solitary dark pigmented plaques which can evolve into nodular, bluish, submucosal and painful skin changes. Lesions resemble those of bacillary angiomatosis. Progression: it may disseminate to the organs, particularly the GI tract, respiratory tract and lymph nodes. Gastrointestinal tract involvement, abdominal pain and diarrhea, hemorrhage and bowel obstruction in severe cases. Pulmonary involvement, lesions cause dyspnea, cough and/or hemoptysis. Cutaneous lesions are the typical initial manifestation of Kaposi sarcoma. However, extracutaneous lesions, disseminated disease, can precede skin involvement. Lesions resemble those of bacillary angiomatosis, and histology is required to differentiate between the conditions. Intraoral Kaposi sarcoma of the palate. Photographs of the oral cavity. Image 1 shows a single purple nodule on the palate. Image 2 shows several purple papules on the palate. These lesions are characteristic of Kaposi sarcoma. Kaposi sarcoma on heel of HIV patient. The purple bluish lesions seen on the heel of this HIV-positive patient are multiple Kaposi sarcoma. The lesion on the left side is elevated, while the other lesions are patches. The causative agent is herpes, human herpes virus 8. HIV patient with Kaposi sarcoma and candidiasis. Oral cavity: the lesion is purple-brownish because of intense vascularization. The white yellowish plaques, which can be scraped off, indicate oral candidiasis. Kaposi sarcoma on skin: a mixture of dark red macules, papules, and plaques are distributed asymmetrically on the skin. These lesions are characteristic of Kaposi sarcoma caused by human herpes virus 8. There are dark red solitary macules, also termed patches, on the side and tip of the nose. These lesions are typical of early-stage Kaposi sarcoma. Violaceous nodules and papules are visible beside several black crusted plaques on the lower leg of this patient with Kaposi sarcoma. A child with HIV and Kaposi sarcoma involving the skin. There are multiple purple-brownish patches located on this patient's skin. These generally painless lesions in an individual with HIV suggest of Kaposi sarcoma. Endoscopy in gastrointestinal Kaposi sarcoma. Flat, dark red esophageal lesions. Polypoid nodule in the terminal ileum, highlighted using chromoendoscopy with indigo carmine dye. Submucosal rectal lesions. tumor of the antrum of the stomach causing pyloric stenosis, flat ulcerating circumferential lesions in the duodenum, multiple stomach nodules. Kaposi sarcoma may affect any part of the GI tract. Subtypes and variants. HIV or AIDS-associated Kaposi sarcoma, most common HIV-associated tumor disease. However, the incidence has been declining since the introduction of antiretroviral HIV therapy. Commonly manifests as multiple cutaneous lesions on the face, limbs, and torso. Classic Kaposi sarcoma usually occur in older Mediterranean or Eastern European men. Iatrogenic Kaposi sarcoma usually occurs in immunosuppressed patients after organ transplants. Endemic Kaposi sarcoma most commonly occurs in sub-Saharan Africa in HIV uninfected individuals. Aggressive disease with lymph node and visceral involvement is common in children. Diagnostics: HIV screening, biopsy and histology of cutaneous or visceral lesions indicated in all patients, spindle-shaped cells, leukocyte infiltration and angiogenesis, immunostaining with a monoclonal against human herpes virus 8 latent nuclear antigen helps differentiate Kaposi sarcoma from other similar diagnoses, for example, bacillary angiomatosis. CT with IV contrast enhancement of lesions. The choice of imaging depends on symptoms and the likelihood of disseminated disease. Chest, diffuse reticulonodular infiltrates, pleural effusion, peribronchovascular nodules, abdomen or pelvis, hepatomegaly, multifocal liver nodules with contrast enhancement, bowel wall thickening, lymphadenopathy, lytic bony lesions and soft tissue masses may also be seen. Additional studies, depending on symptoms, endoscopy and bronchoscopy, may show red purple lesions. Hemorrhage may also be visible. Treatment: the decision to treat depends on whether the disease is localized or disseminated, as well as whether there is any underlying immunosuppression. Specialist consultation is recommended to determine the best course of management. Immunosuppressed patients manage underlying immunosuppression, first-line treatment. HIV-associated Kaposi sarcoma start antiretroviral therapy, chemotherapy, liposomal doxorubicin and paclitaxel, indicated for systemic disease, consider for disseminated cutaneous disease. If feasible, reduce doses of or change immunosuppressive medications. Immunocompetent patients or inadequate response to first-line therapy for immunosuppressed patients. Localized disease, intralesion chemotherapy, for example with vinblastine or imiquimod, cryotherapy, radiation therapy or laser therapy. Systemic disease, systemic chemotherapy with liposomal anthracyclines or paclitaxel. In low-income settings, bleomycin and vincristine have been used, but these are not recommended as first-line therapies as their efficacy is inferior to that of anthracyclines and paclitaxel. Alpha interferon. Prognosis: Prognosis is variable depending on subtype and whether disease is localized or systemic. Classic Kaposi sarcoma has always had a much better prognosis than HIV-associated Kaposi sarcoma. Thank you.